that time of the season, and all through the house, everybody's doing something, playing ball outside, they're making music in the living room, a little mischief in the den. It's good to have everybody home again.
Well, one of the things you have to think about when you have an older woman's health is how do you maintain it? How do you make her do the things that we want her to do in terms of be healthy and prevention? And what I'm going to try to do is talk about interventions, not only in screening, but along issues in terms of prevention of the burden of disease that impacts older women. And that burden of disease reflects cardiovascular disease, cancer, and actually we're going to talk about osteoporosis and not really cerebral vascular disease. We're going to be looking at things that should lead to greater quality of life as well as life expectancy, and they're all going to be unique to women. So if we look at the mortality rates for women, you can see that for each decade of life, cardiovascular disease, that's this blue line here, is by far the biggest leading cause of mortality. And it's second only to stroke. And the cancer risk, both lung, breast, and colon cancer, seem to be remaining steady, maybe a slight increase for colon cancer and a very tiny increase for breast cancer in terms of mortality. And you can see by far and wide, the vast majority of risk is taken up in this mortality due to cardiovascular disease. So let's talk about cardiovascular disease for instance. Well, one of the things you know as women go through the aging process, especially when they go past the age of 50, they stop making hormone estrogen. That's the hormone that allows them to maintain that woman's integrity. Before that, the woman has somewhat of a preventive effect of heart disease in that her risk of heart disease is about 10 years shy of that of men, and that her risk is mitigated by estrogen. And if you look at it, we can see that when we give a woman back her estrogen, once she's reached the change of life or gone into the postmenopausal state, estrogen has effect on one of the major risk factors of heart disease, and that's lipids. You remember that the HDL is the good lipid. That's the lipid that tends to protect your heart from cardiovascular disease. The LDL is the quote-unquote bad lipid. That's the one that seems to promote cardiovascular disease. And there's some evidence that triglycerides may promote as well. Here are the experiments using hormone replacement therapy. This is giving them estrogen plus progestin in a cyclic fashion. That means you get estrogen first, then you follow that with progestins. This is estrogen for progestins in a continuous fashion. And this is the same thing, but a different type of progestin, a micronized progestin versus medroxyprogesterone acetate. And you can see that for all of these, estrogen alone, as well as estrogen with various forms of progestin, it improves the HDL cholesterol. So it makes the good cholesterol go up. It also decreases the bad cholesterol by dramatic amounts, actually. However, if you use a certain type of estrogen, and this particular estrogen was conjugated equine estrogen, that's the Premarin product, you do get a rise in lipids. Now we have had some designer estrogens come on the market, things called SERMs, or selective estrogen receptor modulators, and they also have an estrogen-like effect, except on some forms here. The Raloxifene is the newest product on the market, well, not the newest, but it's the current product on the market that's a selective estrogen receptor modulator, and that estrogen increases, it compared to the Premarin, it doesn't quite increase HDL enough, but it certainly decreases the bad cholesterol, just like the former one. And it has a beneficial effect on triglycerides by lowering triglycerides. Now, we're talking about cardiovascular risk, and I'm harping on lipids because that's one of the major risk factors for heart disease. It's not the only risk factor, but it is one of the major ones. Besides estrogen's effect on lipids, we know that statins are also have beneficial effect on lipids. And this is, again, a various set of statins. This is, again, conjugated equine estrogen in white, simvastatin, which is one of the new statins, in green, conjugated equine estrogen in blue, and pravastatin in yellow. And you can see the increases in the good cholesterol, as well as the various decreases in bad cholesterol. So these are suggestive that women who have cholesterol problems and are at risk for heart disease based on cholesterol will benefit from this. Both estrogen are, the selective estrogen receptor modulators, are statins. Now, if you look at heart disease mortality, giving women estrogen or anything that lowers their lipids probably decreases their cardiovascular mortality substantially, and by a lipid-dependent mechanism, somewhere in the 35% range. But the nice thing about estrogen, it has these other beneficial effects, which probably accounts for its 50% reduction in cardiovascular mortality. It has lipid effects it has non-lipid effects by changing the endothelium, changing the character of the vessels that are going to the heart, has effects by improving insulin sensitivity, and that has a big impact for the population in this particular area that has the high incidence of insulin insensitivity that leads to diabetes. It can decrease the ability of the vessel wall to take cholesterol into it, and it can improve the dilatation effect or opening up of the vessel wall. Let's change gears a little bit and not talk so much about estrogen. There's some other things that women can do to prevent cardiovascular mortality, and that's the issue of aspirin. If you've seen some of the evidence from observational studies that suggest that women who take aspirin a day have tremendous cardiovascular protective effect and benefit. Looking at it in terms of percentage of patients suffering cardiovascular events, you can see that even for those younger than 65, you have a slight reduction in cardiovascular events based on taking aspirin, somewhere about 2%. Looking at over 65, again, a reduction in cardiovascular events. And that reduction may not be as great as men, but it's still significant. Still significant. We also talked about antioxidants, looking at both observational data and clinical trial data, looking at antioxidant vitamins in cardiovascular disease. From observational studies, we originally thought that vitamin A and beta-carotene may have a cardiovascular protective effect. That's kind of plus or minus now. Vitamin C sort of panned out. However, if you look at vitamin E, both in high and low dose, there is some observational data evidence that suggests that this product may be protective. We're still waiting for clinical trial evidence to prove that, but it is some suggestion. Because of estrogen's effects on lowering lipids and cardiovascular disease, people have looked at the essential component of plant estrogens, that's the flavonoids. It appears that we really don't have evidence that flavonoids by itself are cardioprotective. It seems to suggest that there's more than just the flavonoid component. It may be the protein component plus the flavonoid component that's necessary to have estrogen-like effects from phytoestrogens. And again, we looked at folic acid, and the effect of folic acid as cardioprotective seems to be on homocysteine concentrations. And we now know that homocysteine, in addition to lipids, in addition to lipoprotein A, in addition to no exercise, in addition to smoking, homocysteine is also a risk factor for cardiovascular disease in women. Let's move on a little bit, touch on the next subject, and that's the issue of cancer risk. Okay, maybe we won't touch on cancer risk. Okay. Just to show you the changing face of cancer, if you look at the rate per 100,000, how it's changed over the decades, cancer mortality has held pretty steady, except recently, data from 1997 suggests that finally, for the first time, we have a decrease in cancer mortality. The overall rate of cancer, the detection of it, has been steadily increasing. The nice thing, though, is that because the rate has been increasing, is we've really been picking up the carcinoma in situ, or the early stage cancers, and that probably has led us to decrease the incidence of metastasis. So that has been steadily dropping. The overall survival now has started to increase, and that may again explain why we're finally starting to see a decrease in breast cancer mortality. To remind you some of the risk factors for breast cancer: first pregnancy. So all of you who had your first pregnancy really late in life, how many here past 35? Nobody? You're younger than 35? Very good. How many of you had your first pregnancy after 30?
At age 30.
So, okay. Well, it's really 30, 35, so you're safe so far. What about body mass index? Okay, that's another risk factor. Those of you who are heavy, like me, see? But I don't have enough breast tissue to think about the risk. But if you talk about body mass index, the heavier you are, the greater risk you are for breast cancer. How many here are college graduates? Raise your hand. You know y'all are college graduates. You're at risk for breast cancer. I'm not sure what happened. I think it has something to do with textbooks and studying that causes you to be at risk. But alcohol use, if you're drinking and getting drunk. See, I think maybe that's what it is. You're in college, you're getting drunk, passing out. That puts you at increased risk. Delayed menopause, if for some reason you didn't start your menopause until late in life, so if the earlier you start your menopause, the less likely you are to have breast cancer. So if you start your menopause 55, 60, you're at increased risk. And there's a small increased risk if you're currently using hormone replacement therapy. Now, we used to think it was about 12%, and I'm going to show you some data that talk about the hormone replacement therapy breast cancer issue. It's been hotly debated. Just want to orient you to this slide. These are meta-analyses. So these are studies that took other studies, combined the data to try to make some larger estimate on the risk of breast cancer and hormone replacement therapy. This is a line of relative risk. This yellow line here is at 1. So any study that lands on 1 means hormone replacement therapy did nothing to your risk. Didn't increase or didn't decrease. Anything on this side of the line means that hormone replacement therapy decreased your risk of breast cancer. Everything on this side of the line means it increases your risk of breast cancer. And you can see, looking at these meta-analyses, some of the early ones suggested that it didn't have an effect or that it decreased breast cancer. Many of the later ones saw to show that there probably is a slight increase in the risk of breast cancer. However, for almost all of them, this bar here is what they call the confidence interval, and that confidence interval crosses 1. So we're still not completely sure whether or not it does, but I think most people would say that it does have a slight increase in risk. And if you compare that across, if you look at former users, very small increased risk. If you look at ever users, about a 14% increased risk compared to current users, somewhere in the 35% range, 30 to 35% range increased risk. However, this is sort of the good news with the bad news. If you look at the risk of death from breast cancer, it seems to suggest from observational data that never users, if their relative risk is, again, 1, people who had past use of hormone replacement therapy, even though they had a slight increased risk in the incidence of breast cancer, their risk of death from breast cancer was actually lower. And for current users, it was even lower still. So the risk of dying from breast cancer seems to go down with hormone replacement therapy. Let's talk about another cancer, colon cancer. I don't have a whole lot of slides. I don't have any slides about lung cancer because hormone replacement therapy does a little bit in that, and smoking is the #1 cause of it, and of course stopping smoking is the #1 risk reduction. So we didn't deal with that one, so we're going to move it. Colon cancer, third leading cause of cancer incidence and cancer death in women. So all you who think you didn't need to get your flexible sigmoidoscope, your colon screening, you're wrong. You need to get these. The incidence rises at age 40, peaks at age 60 to 75. It's more common in women than men. How many of you knew this? right? It's more common. Most women think that their risk of death is all wrapped up in breast cancer. What's the number one leading cause of cancer death in women? What do you think? Number one leading cause of cancer death. How many say it's breast cancer? How many say it's colon cancer? How many say it's lung cancer? Lung cancer is the number one leading cause of cancer death in women. It's not breast cancer. If you poll women, though, 60 to 70% think it's breast cancer. Not true. Back to colon cancer. It affects more women than men, and you have almost 50,000 new cases annually, of which over 24,000 of them occur in women. If you look at hormone replacement therapy and the risk of colon cancer, you remember this slide? This is the line, means everything on this side means hormone replacement therapy makes it better. Everything on this side means it makes it worse. For ever, current, and former users, looks like the benefit for ever users, for the most part, most of the studies say that there is some benefit. So it reduces the risk of colon cancer. Especially strong for the current users. Former users, not quite clear. Okay? Again, this is observational data evidence. We don't have any clinical trials as of yet to suggest that me giving you hormone replacement therapy will prevent your colon cancer. Just looking at women who have put themselves at risk. Now, we talked about the two major causes of death for women, mainly cardiovascular disease and cancer. Now we're going to shift gears and talk about one of the major causes of morbidity for women, and that's osteoporosis and fractures. The magnitude of the problem affects over 25 million women in the U.S. We have about 250,000 hip fractures a year in women, probably resulting from osteoporosis. That leads to, again, 1.5 million fractures a year. A third of white women, at some point in their life, will fracture their hip. About a quarter of African American women, at some point in their life, will fracture their hips. When I was a fellow in geriatrics, we used to think that African American women and probably Mexican American women weren't going to go out and fracture their hips. They didn't get osteoporosis, they weren't fracturing hips. Now we know that they do get osteoporosis, probably not to the same extent as white women and Asian American women, but they still are at risk, especially in a postmenopausal state. About a quarter of white women will fracture their spines, and that's probably an underestimate. If you look at Mexican American women, we just did a study in this area. It looks like about 30% Mexican American women, somewhere between African American and white women, will fracture their hips over the course of their lifetime. Again, the annual cost is in the billions. That's with a B, y'all, not with an M. So this is an important problem. What are your risk factors? Family history. If your mother fractured her hip, you're likely to fracture your hip. If your mother had osteoporosis, you're likely to have osteoporosis. Ethnicity, we talked about, again, a slight increase for Caucasian women and Asian American women. Early menopause, okay? Early menopause. So if you had your uterus taken out as well as your ovaries and weren't put on hormone replacement therapy, that's early menopause. It could be medical or it could be surgical. Hypoestrogenemia. How many here are marathon runners? I don't have any young women marathon runners? Okay. If you were a woman marathon runner, especially a young woman marathon runner, your periods were probably cessated or stopped, and because of low estrogen, excessive exercise, usually that marathon level exercise will cause you to be hypoestrogenic and then predispose you to have osteoporosis later in life. Same is true for the anorexic and bulimia. So if you got teenagers that having anorexia are bulimics and they're throwing up, they're going to be at risk for osteoporosis when they become older ladies. Thyroid disease, as well as cigarette smoking. Let's look at replacing the hormones and its effect. If you look at estrogen, again, this is mainly conjugated equine estrogen data and its effect on bone mineral density, which is the evidence that there's enough bone at the hip to prevent fractures. You can see that for all forms of these estrogens, they have an increase in bone mineral density compared to baseline. If you correlate that to fractures, again, this is our relative risk line. Blue are the ever users, white are the current users. There seems to be a risk reduction for estrogen use. Somewhere around a risk reduction around 30% for ever users and around 55% for current users. Let's look at one of our SERMs. We talked about Premarin, now we're talking about raloxifene. Raloxifene also increases bone mineral density at the hip compared to placebo. Doesn't quite do it as well as Premarin or conjugated equine estrogen, but you still get some benefit from an estrogen-like product like raloxifene. Besides these estrogen-like components, there are other therapeutic options for hormone replacement therapy to prevent these fractures. Fractures at the spine, fractures at the total hip, fractures all over anywhere in the body. If you look at green is placebo, this is alendronate. Again, this is comparing it to estrogen. You can see in the spine, using a biphosphonate like alendronate, you get almost the same protection that you get from estrogen. At the total hip, exactly the same protection. Total body, maybe a slight difference, but there is some evidence that you protect yourself in terms of improving bone mineral density. And finally, calcitonin, which is the nasal spray. In women that were early in their menopausal years, effectiveness has not been demonstrated, but if they're light, that is, women in their 60s, 70s, 80s, there seems to be some improvement in bone mineral density and seems to prevent bone loss. So part of the controversy has been the issue of increasing bone mineral density versus decreasing fracture rates. Bone mineral density seems to suggest anytime you get above 2, you seem to have, and that's 2% increase in bone mineral density, you seem to have some protective effect in decreasing fracture rates. And these drugs, conjugated equine estrogen, alendronate, calcitonin, and I think the evidence is pretty clear on raloxifene as well, although the data is still coming in, seem to reduce fracture rates. Calcium, all these women, every study I showed you, they were already on calcium. So you need calcium anyway. However, calcium by itself, while it does increase bone mineral density or decrease the loss of bone mineral density associated with the change in life, does not seem to have any impact on fracture rates. And look at this. The biggest increase in bone mineral density is with fluoride. So why don't we use fluoride? Well, actually, the study that used fluoride, although it has the greatest increase in bone mineral density, actually had an increase in fracture rates. So it looked like what happened was they were getting more brittle bones, although their bone mineral density, or the bones were thicker, they were just more brittle. So, in closing, we're coming to the end. Things you need to do for improving lifestyle. You saw me sell the argument for estrogen. One of the major things is weight loss. We've talked about cardiovascular risk. It's an increased risk for cardiovascular disease as well as cancer. So losing weight. How much weight are we talking about? Are we talking about 40 pounds? No, we're not talking about 40 pounds. We're talking about percentages in the 5–10% range. So if you have a woman who weighs, let's say, 200 pounds, we're talking about a 10–15 pound weight loss. Y'all do that in a month. Okay? Dietary intervention. What do we mean? Low-fat diets. If you're prone to insulin sensitivity, it might also imply at least a modification of carbohydrate intake of the diet. But definitely low-fat diets for cardiovascular risk. How many here smoke? Good. I'm so proud of you. Smoking cessation. Probably one of the leading risk factors that you can intervene on for all these diseases, including cancer, cardiovascular disease, and osteoporosis. If you can get women to stop smoking, you have enhanced their quality of life and improved their risk of death. Not improved their risk of death, decreased their risk of death. Regular exercise. How many here exercise? Okay, when we talk about regular exercise, we're talking about at least 3 to 4 times a week, 20 minutes per session, not including warm-up, not including cool-down. You can't cheat. Okay? But again, any exercise is better than no exercise, and we now know that. So if you just be able to get out once a week, that's certainly better than nothing. And control of hypertension, diabetes, alcohol consumption, and lipid normalization. So if we're talking about cardiovascular risk, that obese, hypertensive, diabetic woman that I know we've all seen, we have to control the diabetes, because behind that comes lipids and hearts. So diabetes is a major risk factor, especially in women for cardiovascular disease. So that's essential that we try to control these other risk factors. And that's it for me. We can take some questions now and talk about some of the issues we talked about.
Well, it's that time of the season, and all through the house, everybody's doing something, playing ball outside, they're making music in the living room, a little mischief.